Well, hey, it never fails. Someone always asks me, hey, Heather, what about? And honestly, that's where the best conversations begin. I'm Heather Shaw, certified functional nutrition coach and Pilates educator. After walking through my own wellness journey, hello 80-pound weight loss, I now light the path through my program, The Plan, complete with protein-forward recipes, hormone know-how, and a lifestyle for longevity. This is the Exquisite House Pilates and Wellness podcast. Hey, Heather, what about? We're diving into all things movement, menopause, metabolism, and more, especially the stuff no one warned us about. I tell it like it is, but always with a wink and a hug. No perfection required, just consistency, curiosity, and better questions, served up with a side of sass. Well, hey, so we are continuing our amazing World Menopause Day podcast today with Dr. Erin Adams. Erin is a dermatologist who has a very interesting is not even the right word, an amazing passion for women and women's health. And she is one of my compadres in arms. Whenever she comes into the studio, we are constantly talking about menopause. If any of our favorite people that we follow put something up, we're both the first ones to say to each other, did you see this? Did you see this? So I love Erin's zeal and passion for women and women's health. And so that was a reason that I wanted to make sure that we included her in today's podcast. And so, Erin, tell us a little bit about you, how you got into what you're doing, and why you have a passion for women's health.
Well, Heather, thanks for having me on. Some people might say, well, why is a dermatologist involved in like hormone therapy and women's health? But it's kind of come from a natural progression in my career, starting way back when I was trying to decide for a specialty in medical school, and it felt like this natural draw to OBGYN. And I enjoyed the aspects of clinic and procedures and women's health back then, but realized quickly I didn't love the craziness of deliveries. And so it was always in the back of my head. And I've fortunately had joined the Navy and got an opportunity to kind of go back to the drawing board and figure out what I wanted to do. And dermatology fit that bill. But then I had to go through a stage of being a flight surgeon. And that was wonderful in the fact that I grew professionally and really began to trust my intuitions and sort of my limitations. But as a result of being one of the only female flight surgeons, I kind of landed in a gynecology role during that primary care time. And so I didn't mind the area. Is what and I have a picture in my office now of me holding a baby, and this was during internship, and I think I delivered more babies during that month rotation than any other intern who wasn't a categorical OBGYN, and it was the first time like the mom thought of me as the doctor, and I remember that and have it in my office because she gave me a picture of her baby and me, the doctor who was an intern, but I think I didn't mind the area because I had been interested in it. So fast forward, I go through dermatology and had an opportunity to train with a vulvovaginal specialist in dermatology named Dr. Libby Edwards in Charlotte, North Carolina. And she's one of the pioneers in the International Society of Vulvovaginal Diseases because it's one of these areas of medicine that no one really owns. It's kind of a transitional zone down there. Regular skin to sort of this mucosal skin, kind of like the inside of the vagina.
Yeah.
OBGYNs they want to come in, they want to see the cervix. And a lot of dermatologists aren't comfortable in the area. Urologists, gastroenterologists don't kind of care or know a lot about it. So I took some extra training in that so that I could feel more comfortable and have more knowledge. And then I think more recent, and because of that, I teamed up in the Navy with an OBGYN at Walter Reed National Naval Medical Center, and we had a joint derm-gyn clinic 2 to 4 times a month for a few years because they don't get the training in the skin and the like different topicals and different formulations that we do in dermatology. And I
Yeah.
needed her expertise in some of the more anatomical or sort of, gynecology specific things that I
Yeah.
didn't get specific training in, having not done that residency. So I think, it was kind of a natural progression that I didn't mind the area, realized there was a need for people that knew something about the area, and so many women, especially postmenopausally, are so distraught about itching or burning or pain, or
Yeah.
and I just saw the need and kind of help in my career to try to fill it, because I feel like I have a little bit more knowledge than some of my colleagues in the area.
Yeah.
And that's kind of where I got the passion from, sort of just being the only woman for a while in the Navy clinic, and even having to treat my friends and fellow pilots, do their pap smears
Mm.
and all. And then that sort of niche that we filled in the military with my
Yeah.
gynecology friend. Shout out to Dr. Schwartzman, who's
Oh,
still practicing.
love that.
And we had a great learning from each other, and also to help the patients.
That is great. And talk a little bit about the vulvovaginal kind of aspect of menopause with us. So I know what that is all about, but the people who are tuning in and listening to us today probably have no earthly idea what we are understanding as some of the unique aspects of what happens to us during perimenopause and menopause.
Yeah, so everything dries up. Um, Hormones give us lubrication, so that's one thing. There's hormone receptors all over our body, but specifically in that area are where we urinate from. It's called the urethra. That has receptors for testosterone, and it's very affected by that and estrogen. And as perimenopause, kind of the crazy fluctuations of hormones, goes into no hormones. I mean, essentially
Right.
like almost like castration,
Yeah.
0 level.
Yeah.
Those tissues don't have the support they need. And, way back when they used to call it senile vagina. I mean, thank God so many terms have changed.
Yeah.
And then for a long time they called it atrophic vaginitis or atrophic vagina, um, vulvovaginal atrophy, which is just, everything shrinks up.
Uh-huh.
Um,
Uh-huh.
and then around 2014, a new terminology came out, the genitourinary syndrome of
Yeah.
menopause. And even more recently, there's been proven studies that vaginal estrogen replacement can help decrease urinary tract infections, which if anyone had aging parents or aging, older women in their lives, there's a lot of back and forth with urinary tract
Yeah.
infections, and even ending up, a little um, cognitively just going a little crazy if they have a septic event where
Yeah.
your infection gets in the bloodstream, they can end up in the ICU. All can be prevented with just a little vaginal estrogen. And that's just the urinary tract, not to mention, you know, pelvic pain, pain with
Yep.
intercourse,
Yep.
all these things, just dryness and comfort with just wiping. There's so much that changes during the transition of menopause in the vaginal area.
Yeah.
And the estrogen, local estrogen treatment down there can help with urgency and bladder conditions as well. All the things where people have leakage and all the contact dermatitis that urine eh, creates against the skin, kind of like babies in diapers,
Mhm.
as we get
Mhm.
older, to wear pads or panty liners or Depends, really can be changed by adding that hormone and strengthening those muscles.
That's amazing.
And
I
everyone should be on vaginal estrogen replacement. It's
and
not systemically absorbed after,
right.
once you're going through menopause or perimenopause and having symptoms. There's really not an instance, even breast cancer, where someone should not be offered that therapy. And I think in my practice, that's one thing I see. I'll see they're in for a skin check and they say they're on Bactrim for chronic UTI or something, and I say, "Oh, have you been on or been offered vaginal estrogen?" Which I used previous to a lot of these new
Mhm.
guidelines coming out, just for um, treating lichen sclerosis, which is
Yeah.
a skin condition down there. And so many women are just misinformed
Yeah.
because of a badly interpreted study in the early 2000s,
Yep.
and don't, either they're physicians who don't have the knowledge, or they are fearful of any estrogen, any hormone,
Yeah.
when local estrogen is definitely different than what that study even tried to evaluate.
Yeah. Yeah. And so we've touched a little bit when we were interviewing with Karen, we were talking a little bit about this. And so what we're the study you're talking about is the Women's Health Initiative that was put out in 2002, I believe. And they talked about specific hormone replacement that actually in the study was purported to cause cancer, and even if I'm not mistaken, specifically breast cancer. And so that study was actually disproven a year later, but unfortunately, there was too much public kind of promotion of it. And so it really changed the path of how we treated women for the last 20 years. If I'm not mistaken, that sounds about, am I off? Am I on?
Yeah. No,
Okay.
and I graduated medical school in 2002, so it was,
Yeah.
I mean, overnight, like, 40% of women on hormone replacement just stopped.
Yeah.
And there's graphs out there now too that show hormone replacement, like, pre-2002, decreasing
Wow.
while antidepressants use increases
Yeah.
because the symptoms are still there.
Right.
And that study, one, was with different estrogens and progesterones than what we use now.
Right.
They were synthetic, very
Right.
kind of high dose, and
Yeah.
the women were older. So we now know that if you start systemic replacement or therapy within that first 10 years of menopause, there's some great effects of it.
Yeah.
Also, their placebo group, which is supposed to be the group that you compare everything to, a lot of those women had been on hormone replacement even though they were off of it during the trial, but they potentially had some benefit
Mm,
from having had that, in the past. Anyway, it was misinterpreted, and then the media sort of they had a press conference, which is totally wild that
yeah.
a study from NIH, like, ends up with a press conference, but they stopped it early due to increased risk of clots, supposedly breast cancer and cardiovascular disease. But again, it was not, it can't really be extrapolated to what we do now because we
Yeah.
started earlier. We have quote unquote bioidentical formulations by the FDA now
Yeah.
with the hormones that our body actually produces. And in that study, for example, they were giving Premarin, which is, equine, horse derived, so estrogens from horse, female mare horse urine.
Right. Right.
That's not what we do now. We
Right.
have estradiol, which the actual formulation is the exact chemical structure of what is found in our body. So a lot of things that can't be compared apples to apples from that study.
Yeah. And that I think is the important part of what you're talking about. I think you having the experience and the vocation puts a little more weight to the conversation of what we're talking about. But I also think that your passion for women's health um, is a great platform for us to be talking about this. I mean, we both are very passionate about women getting hormone replacement if they believe it's the right choice for them. I'm a little partial myself. But I love that you're talking about the specifics of this and really getting into the meat of it because there is so much misinformation still. And there's so many clients that I see, and I'm sure that you see that are still a little bit confused and still wondering like what the heck is going on. And the reality is exactly what you said. There's two different types of things. There is what we actually take that impacts our system, and then there's topical, which doesn't impact our system. So the transdermal patch for estradiol is kind of the gold standard as far as estrogen replacement. And then progesterone, the gold standard is a pill. And then the vaginal estrogen is topical for vaginal atrophy and GSM and those sorts of conditions that happen through menopause Mainly menopause. I mean, does it start in perimenopause, I guess, is the question, and can it?
It does. There's a whole transition period, you know? I mean, the average age of menopause in the US for mostly Caucasian women is 51. It varies based on ethnicity a little bit too, and genetics. And then there's, people that are surgical menopause, et cetera. So the
Yeah.
age can vary, but there's a huge transition. And an average is an average for a reason. There's, on either side of the age of 51, people are going through. And I think lately there's been I think maybe as women physicians especially start going through this and start realizing that there's the data is flawed and why aren't we offered these treatments.
Mhm.
There's been kind of a surge of menopause data and information and Instagrammers, and menopause shouldn't be a niche specialty. This is something we have, half the population is women.
Yeah.
Every physician should be this should be important to every physician and every person treating women for whatever
Yeah. I'm
organ system that they're specializing in. Because it really affects all of them. And even the Women's Health Study showed decrease in colon cancer risk, improved bone mineralization, and a lot of that didn't get brought out to the public.
Yeah.
And even the absolute risk of breast cancer in that study was only an additional one woman per 1,000.
Mm.
And so if you put it that way to a woman and they know their family history and they know their risk factors and their lifestyle and all the other things that contribute to breast cancer, like having the education
Yeah.
and giving the woman the empowerment to make the decision for themselves should have been what the takeaway was,
Yeah.
you know?
Yeah.
Yes, the risk went up 24%, but what does that mean in people numbers?
Yeah.
Uh, we kind of misled and a whole generation of women just due to bad interpretation of statistics.
And aren't we glad our generations are taking it back?
Yeah, and I'm the first to say I don't love statistical analysis, but, you have to delve into how does this apply to today and how does it apply to real life?
Yeah, exactly.
And even, for instance, yes, you said that transdermal estrogen is kind of the gold standard. It is because it bypasses the liver. There is a decreased risk of clots. But even in oral estrogen, which is probably not people, providers' top prescription
Yeah.
for hormone therapy, even that has less risk of blood clots than oral contraceptives,
Wow.
which are
Wow.
high dose.
Yeah. Yeah.
You know?
We don't think about that.
And
That's
even that, if I remember right, our baseline risk in women is like 3 per 10,000 women to have a blood clot. Oral contraceptives might be 6 per 10,000 women. It's not, when you put it that way, it's
not
not
it's not
huge.
that bad. Yeah.
And if
Yeah.
it's less than that for an oral estrogen, then transdermal, goodness,
Yeah.
you
Yeah.
know?
Yeah. And this is the stuff that I think, we know, like, you and I know this because we read all the stuff. We've we've read all the things. We attended all of the things. We this is our, like, little niche of passion. But talk about from your specialty now, what happens to our skin and all of those types of things when we start to lose estrogen and go through, and hormones really, and go through menopause. What changes do we see there?
Lots. But I have to tell you one thing. I have an admitted book problem. And the fact that menopause books show up at my door from Amazon almost every day.
Your
And
poor
I'm
husband's like, "What?"
Ooh, used good, $3? Check. I need to read that book because there's just the information is
Yeah.
like skewed, and you need to. I found myself. I've always been really good at, even in studying for dermatology, which is a lot of reading. Yes, the hours and the hours may be good. Emergencies may not be
Yeah.
as much of a part of my practice, but the vast volume of information to know for our board exams was a lot. So a lot of
Yeah.
reading. And I've always been really good at kind of taking the big picture and distilling it down to a one pager. And I feel like
Mm.
that's what menopause right now, because you have Instagrammers, you have, these experts that are writing books, both MDs and sort of, you know, um, s- uh, news broadcasters
Yeah.
or
Yeah.
or actresses. And I feel like that's one of the things that I wanted to do for women is distill some facts and education and then be able to offer that menu,
Yeah.
which everyone, our moms should have had, a menu. And then you look at your individual risk and have the conversation because it's not a cookbook.
Mm-mm.
It's not,
Mm-mm.
everyone is individual, and
Yeah.
that's the problem because it needs more than 10 or 15 minutes in a gynecology office to really, because menopause affects so many aspects of our body, but
Yeah.
specifically skin, lots of things. Um, Collagen is number one, and that typically starts decreasing in our 20s and 30s, like 1% per year. But then around the perimenopause and that first 5 years into menopause, up to 30% of our collagen is gone.
Oh,
By the end of menopause, that 50% is gone. And what does that mean? It means our skin thins and people start caring about sagginess and structure and just the luminosity of the skin.
mhm.
Uh, and they wanna go back, and they wish they had time back. A lot of women and men start talking about, as they age, but specifically, like, thinning on their forearms and
Mhm.
bruising, and there's not a great way to reverse that. Um,
Yeah.
Retinoids are probably the best thing for collagen, but and sun protection. But then folks get itchy. Their skin barrier is not as good. So I always tell patients your skin barrier is kind of open to the world. So
Yeah.
perfumes and fragrances and soaps can irritate you more as you have less water and hydration in your skin. And that's just part of the estrogen. If you think about it, it's that, hormones stimulate lubrication. Think
Yeah.
about the
Yeah.
oily teenager. Uh,
Yeah.
the same thing happens in the vagina, same thing happens in the skin. You were oilier, people think they don't have to shower as much because 'cause they're not as oily or not wash their hair as much because 'cause they're not as oily. So the skin becomes more dehydrated, and sometimes that
Mhm.
can, result in itching. Age spots or the brown spots, sunspots, sun damage is not something we cure, it's something we manage. I always tell my patients that because it's not a one and done. There's a lot of things in medicine
Oh,
that we control, we don't cure. And a lot of things in skin are the same way. I tell folks, you take a pill every day for your blood pressure. If you didn't take a pill, you'd have high blood pressure. Same with your diabetes. It's not cured, it's managed. And the
yeah.
eczema and dryness and brown spots and things, sun damage, we have to manage as well.
Yeah.
Acne can become a real problem, especially in perimenopause,
Yeah.
because perimenopause is it's almost like your it's like driving around with nothing to tell you how much gas you have.
Oh,
Sometimes you
yeah.
get in the car and you're on empty, and sometimes your husband filled it up and you didn't know, and at some point you drive and you run out of gas. Well, same thing with the hormones of perimenopause. It can be
Yeah.
0, it can be high, like almost pregnancy high, it can be in the toilet 2, 3 weeks later. And that plays a lot on people's facial skin
Yeah.
and their receptors, especially in the jawline. Hormonal acne kind of affects the jawline, the upper neck.
Mhm.
I like to say kind of where a man's beard would be, whether
Yeah.
that be androgen receptors, testosterone receptors, kind of in that area, because our estrogen's kind of going wacky.
Yeah.
And believe it or not, women actually have more testosterone in their body. If you equate the estrogen and testosterone levels, they're measured in different values,
Mhm.
but
Mhm.
um, and women actually have more testosterone than estrogen in their body, believe it or not, which is a
I
whole
believe
nother
it.
conversation about
Yeah.
why we don't have testosterone as an important part of,
Yeah.
FDA approved treatments for women. But
Yeah. It's
so those are some of the things: hydration, skin barrier, collagen, which is wrinkles, sagging, luminosity, and like age spots and acne. Those kind of all start coming up for some people as we hit the perimenopause, menopause time frame.
What are your go-tos for treating those things in women? Like if I walk in your office, which we already know I want to do, I'm ready to go. I'm due for my appointment. We've been talking about it for like 3 months.
I think again, so much. misinformation out there and, have to start Botox when you're 18.
Mhm.
I mean, there's some truth in some of this stuff, but everyone has their little platform and making their money on Instagram and Facebook since COVID, I think. But so what are my go-tos? Sunscreen. The
Mhm.
sunscreen and retinols are number one, the most proven, most science behind them. Sun expedites the aging process, thins the skin, it expedites the loss of collagen. And you will see on internet pictures of either a truck driver who's driven 40 years of his life and his left side is
Yes.
more aged, or even a person who has a window in an office where they've worked 40 years and there's so much damage on the side that faced the window. So
Yeah.
sun protection, number one, and a lot of women in their 40s, 50s, 60s and older are then upset about their neck and their chest or their forearms and their hands. And they are like,
Mhm.
that shows my age. There's a sharp cutoff
Yeah.
of sun damage at the jawline.
Yeah.
So if I could tell anyone younger to carry the sunscreen down and think about hands and forearms, because those are other areas that give people problems and cosmetic concerns as they age.
Yeah.
And sun protection, 30 is usually enough, but we're supposed to use a golf ball amount for our whole body every 2 hours, or about a teaspoon for our face every 2 hours. That's how it's studied.
Wow.
An ounce, a shot glass full. Most sunscreens are 6 to 8 ounces. So imagine if you truly used an ounce on your body every 2 hours. You go that bottle typically
Would be
lasts you
gone.
2 summers.
Right, right.
And so I tell people, yeah, there's no benefit in over 30 technically if you're using it like the studies,
Wow.
but we're not. So we're not always getting what's in the bottle. And anything with zinc in it, it's going to be a little longer lasting because zinc kind of is a reflection. It doesn't chemically deactivate. Iron oxides in sunscreen are really good because they help with pigment production and also help prevent against visible light and infrared light in terms of
Mhm.
stimulating our
Mhm.
pigment producing cells. And then if you're on a good regimen of sunscreen and a retinol, and you know me with retinol, I am a lazy, keep it simple, stupid. I'm not going to use something if I have to do a pea-sized amount, wait 15 minutes before, um, because retinols sometimes are hard to tolerate.
Yeah.
And before I started kind of mixing some things in my palm every night, I could barely use an over-the-counter retinol.
So tell
And
tell people this. Tell people this because this is gold. This is dermatologic gold right here. So tell people how you do this. This
well, I
is
do.
your
I mean, I kind of switch around things. I am kind of a cosmetic, skincare guru, junkie in a way. I like to
yeah.
try new things. Martha Stewart came out with something recently. I'm like, I want to try it. I used to be always the one that if a patient asked me about Rodan and Fields, I'm like, okay, I'm gonna try it. Like, I just want to know
Yeah.
what they're asking about. But
Yeah.
yeah, so titrating up to the highest retinol you can tolerate sometimes requires either like a sandwich method where you put on um, skin moisturizer, then the retinoid, then the moisturizer again, or I just kind of mix it all together. So um, retinol and sunscreen being number one for anti-aging, but then you have things like peptides and vitamin C products, which can definitely help with antioxidation, and hyaluronic acid products that can help with hydration. Um, but basic, good gentle cleanser, SPF that you like and tolerate, and then a retinol that you slowly march up from either an over-the-counter, like an Avene or retinol,
Uh-huh.
to a adapalene over-the-counter, which is also different. 0.1 used to be by prescription only,
Mhm.
and then to tretinoin, which in most instances is under $50 with GoodRx, which is a coupon you can take to
Yeah.
CVS or Kroger and get the gold standard tretinoin. And then there's three generic strengths of that, and then you can even go to Tazorac, which is
Oh,
a stronger retinoid. And I know a lot of dermatologists that use Tazorac because that's the strongest one. And if
wow.
you can march up slowly to using it every other night, or certainly every night if you can tolerate, that would be great. But there's a few peptides, and it's hard. They're all over the market.
Mhm.
what works, what doesn't. I'm also not one that believes in spending hundreds of dollars on skincare.
Thank you.
And there's more to skincare than just what you put on. It's also what you put in, you know? And I know you know all about
I
that.
know all about that. We may talk about that soon.
Yeah, and oh, one thing I totally forgot was hair loss is affected during menopause.
Yes, yes.
And if people just knew to expect it and maybe they could do something in their 30s or 40s to help prevent it, that would be something that could be useful for folks as they learn more about menopause. Um, but yeah, I'm not one that believes in really expensive things. There's a few peptides. There's a company locally called Brandify that really kind of takes the
Need to know
Richmond-based
about this.
company that takes
Ah,
dupes of expensive products and kind of, tries to make it more affordable and take away that sort of packaging markup,
nice.
or brand name sort of markup. Um, but it has to be something you're going to use too.
I love that. So of everything that we've talked about, the one thing that there's a couple things that you actually have in your office that I love that I have to tout a little bit. So if you're in the local Richmond area, Erin's practice is Midlothian Dermatology, and they're amazing. The team is amazing. It's a very homey kind of family feel to the practice, and I really appreciate um, everybody in there. So the things I love are the sunscreen, which I know was not your formulation. That was Dr. Joe Bohannon was the founding doctor of the practice, and she kind of worked on development of that, which is a really nice sunscreen. It also gives an amazing kind of um, primer quality to pre-makeup skin prep. And then I also love the cleanser that you guys have that um what the heck is it? Is it mango or papaya or something?
Papaya.
Yeah,
Yeah.
I love that. And then you also have a really nice cream moisturizer that comes in a little pot. That
Yeah.
one's
That has
really
some apple like stem cells in it.
yeah,
Yeah, I totally agree. I one tout my colleagues that I work with, both Stacy Romero, who's a PA, been there 20 plus years, and Lisa,
yeah.
um, uh, who it does mostly lasers and cosmetic procedures. But when I started there, they all touted the sunscreen. Oh, whatever, like it's just another sunscreen. But you're right. I kind of have become addicted to the sunscreen, and that's a lot to say for me because I like use things intermittently. But a lot of patients will compliment my skin, and that day might have been a day I was like, oh yeah, I remember this specific sunscreen because it does
Mhm,
have a little primer effect
mhm.
to it.
Joe had no idea she was gonna get a fan club with the sunscreen.
Right, right. Yeah, that's probably our most popular seller, and anything with sunscreen in it, I'm, like, all about.
Yeah, I love that. So I want to go into I wanna make sure that I covered all of my, we talked about, like, your go-tos. Is there anything that you think is very underrated that's kind of a power player in the skincare world for us in this phase of life? Do you think that the copper peptides are a winner? Do you think that if that's more internally kind of
I don't know,
addressed or
I mean,
topical
I
or
still think retinol and sunscreen, and then I mean, there's lots of stuff coming out. I think regenerative medicine, especially in skincare, but it goes for joints, everything is kind of the
Mhm.
wave of the future. There's a couple biostimulator sort of fillers that have different properties, but can stimulate your own collagen. So
Mhm.
that's one thing. There's a couple like procedures, like microneedling, radiofrequency microneedling, old therapy, soft wave. They can sort of stimulate and help collagen. And then I, I think you have to look at products and see where they come from. Don't
Mhm.
just look at who's promoting like Instagram, but like
Mhm.
find the website, look and see if they have a study. Um, there's one made by a few PhD chemists, a peptide called OS01,
Mhm.
and it shows studies that it has almost the same effect on the thickness of the epidermis as um, retinols. So there's
Wow.
different things like that, or I think SkinCeuticals has a vitamin C that's touted to be very good. Brandify kind of like did a dupe of it. So
Mhm.
there's definitely some things worth a little spending a little. But I think, of course I love our sunscreen, but also like CeraVe sunscreens, tinted sunscreens are also really, really adequate for the basic purpose of helping to prevent aging and collagen loss.
I love that. I love that. So I think we've covered everything about skin and like the specific questions I had saved for you. I just wanted to make sure I didn't miss anything. So let's get into our core questions.
Oh,
Why are
goodness.
you passionate about supporting women in midlife and menopause?
I think, as I've gotten older and been through a little bit of the beginnings of this transition, I think I've become more passionate because I felt like that I didn't even know. I mean, this is 5 years ago and all these things were happening. I had no clue it was perimenopause. And here I
Mhm.
am, a very educated professional woman who was leading a group of like 25 people and having anxiety, self-confidence issues, some other, other joint things, thinking like, is this what people with fibromyalgia feel like?
Yeah.
So I think my passion has changed even more in the last decade because of delving more into this information about menopause,
Yeah.
but also just this sort of patriarchal everything around women's health because studies just weren't women weren't in studies,
Yeah.
and so we've extrapolated a lot of things in medicine from studies on men and and then this whole women's health initiative has left millions of women with it's kind of a travesty and a disaster in medicine
Yeah.
in a way
Yeah.
that we didn't have better interpretation of data back then to help women. So I think becoming more educated, I've started having this passion, and then more recently with a sister and a neighbor and some other people just not getting good care and answers about menopause, even from local supposed experts or
Well,
during, the last 20 years, 25 years, people are kind of going to back alley sort of, oh my gosh, they're taking a hormone replacement, but gosh, not from their gynecologist,
yeah.
like, it was not talked about. And I'm so glad it's being talked about now. And one of my other passions is to use what your insurance can provide for you.
There
There
you
are
go.
so many people that have developed these like little niche things and compounded creams, and it's like, what's in it? Who's it come from? There's just a lot of sort of wild, wild west medicine. Is the
Mhm.
top of this compound like the bottom? And there are some people that need that very individualized care. But if there's something that's been studied thoroughly by the FDA and your insurance covers it and it works for you, why spend hundreds of dollars, thousands of dollars a
Yeah.
month for
Yeah.
things that may or may not have better action for you? And we don't know. Like there was a whole time where women were getting compounds of biest, which was estriol, which is again not something our body mainly produces,
Right.
and estradiol in a small percentage. And it's like, does that even help the bones? You know,
Mhm.
we have this study from Women's Health that says estrogen helps the bones, but I don't know. So there's a lot of questions. We don't have all the answers, but those are some of the things. Just trying to distill information, help people not just spend tons of money without data behind it,
Yeah.
and interpret the data, interpret what's out there, kind of in a logical manner
Yeah.
for women.
You're gonna have to make a library out of all those books you've got.
It's kind of funny.
We're gonna have to put them somewhere that people can check them
Well, I
out
can't
real.
give them to people because, I've, like, highlighted and underlined
Right.
'cause I'm a very active reader. I'm not a Kindle type person. I have to, like, to pay attention.
I
I
love
have to
that.
be engaged, for
You
sure.
so of ev so I say I'm joking, but I really appreciate where you're speaking from in all of this because I feel like this is the passion part of being a woman and then going into this phase of life that I mean, you know me, anybody walks in the studio, it's like they get handed the menopause checklist and, what's under the hood? What are you doing? And what are you eating? How are you working out? How are you sleeping? All the things. And, that was kind of what sort of brought us a little bit together on all this.
Well, it's
And
been
I
sort of taboo for a while, people not
Yeah,
talking about what's happening to them,
yeah,
and people just being told by medical professionals that it's just part of life, suck it up, like, and that's not true, like, there are options,
yeah.
and that's where we are now. I remember just even recently my mother, um, commending my sister and I for, like, taking care of ourselves, and we were talking about pelvic floor physical therapy. And we're at, like, a Mother's Day brunch, and I was like, "Why are you bringing this up?" But but the fact that she never felt empowered to fix things that were
Oh,
wrong, and now we have, like, not only a prescription that can help, but just the knowledge and the conversation that this is normal, and this is something that people are normally going to experience, and there's something to do about it,
yeah.
instead of just accepting it and buying more Depends.
Yeah, yeah, and I think, um, to go in I wanna, like, kinda go down that rabbit hole a little bit because we've talked about this a little bit. Both of us have been to pelvic floor folks for our own bodies to just kind of help improve or just get perspective on what's going on, and I know for me, there was a lot of discomfort, a lot of the things you talked about, the vaginal atrophy, the different kinds of, um recurring UTIs, that kind of thing. I was just like beside myself. And I was very happy that my doctor had referred me to a pelvic floor PT. There's not that many in our area, but I really like the one that I went to because I really felt like she was so knowledgeable and so passionate. She, at some point, I would like to interview her for the podcast, and we've talked about it. She has a whole talk, a 45-minute talk on menopause and pelvic floor and the impact there and what we can do about it. And I don't know about you, but for me, just seeing her in the session package that I bought with her, my body is completely different on this side of things. It's drastically changed how I can function. And 100% of that is the exercises and then the vaginal estrogen because that has changed. I mean, how I'm supposed to apply that is different. How
Mhm.
often I'm supposed to apply that and I know that my doctor prescribed that, but I don't know that she gave me as much instruction during the time that, we had our little exam and she said, "Okay, I'm going to write you a script for this and I want you to, put this on." But we didn't talk about like, I want you to put it on every day. I want you to do it this way and, all of
Right.
that. And I think and not to
The
disservice my
practical
OB-GYN
stuff.
because I love her, I adore her, but it was very much, yes, the practicals of being in a place where someone is dedicated to the work of helping us in our pelvic floor and understanding the anatomy down there and where things were, um, what muscles were impacted because there's a gazillion muscles down there. It's like
Mhm.
unbelievable how much stuff is down there. I'm like, holy cow, I didn't know all this was there. And everything goes
It is.
sideways and crossways. And I feel like learning from that time changed everything that I did, and I agree with you, like, I remember my mom having lots of UTIs, but she didn't have hormone replacement, and she'd had a hysterectomy very young, so younger for a
Yeah,
woman, so to know now where I am, I'm like, I don't want anybody to go through this, and I really have a passion for telling people.
yeah, and I think another point too is even if you're on systemic, say a transdermal estrogen patch, it doesn't always affect the vaginal and vulvar tissue and
Right.
kind of help with UTIs as much as a local estrogen can. So
Yeah,
it is not wrong and totally expected that people would be on both.
yeah,
And pharmacists and insurance companies sometimes balk at that,
they do.
but the science supports it. Um, Even recently, I think you're right about, gynecologists kind of not here's your estrogen, it'll make sex more comfortable, less dryness. But that whole genital urinary syndrome or menopause and how just doing vaginal estrogen or DHEA, which is converted to estrogen and
Mhm.
testosterone, can decrease the expenditure of Medicare on urinary tract infections and hospitalizations and
Yeah.
multiple cultures and by billions of dollars.
Yeah.
So
Yeah.
it's not just a women's problem, it's all of our problems. We're all, paying taxes and getting Medicare funds eventually in our life. So,
Yeah.
getting that education, like you said, about why. My mom recently had a urinary tract infection. And my question was like, "Are you taking your vaginal estrogen?" "No, I haven't done it very regularly in a while." "Well, how long's a while?" "6 months." I said, "Well, you gotta start all over again. You gotta do the
Yeah.
daily for 2 weeks, then back off because it's like you are brand new." And she would have just started back twice a week and been okay after a few months, but, like, and how much did she just in that last couple days, like, feel miserable
Yeah.
and just not comfortable and in pain and didn't end up in the hospital, but went to the ER, got a CT scan because she thought she might have diverticulitis, all these things.
Yeah.
Um, and how much did just that episode cost when perhaps it all would have been prevented by consistently using that for more than just comfortable sex,
Yeah. Yeah. Well, and it
I have a high fem chair. I don't know if you've heard of that technology at the office, but it is equivalent to about 10,000 Kegel, you know, contractions. So a lot of women just
that's
find the
right.
time to do the exercises. I'm one of them. I sometimes have struggle with an all or nothing sort of
Mhm.
problem. If I can't do it well, I don't start at all. But some of these technologies, that Imcella is one of the FDA-approved products. It kinda is a
Mhm.
chair that looks sorta like a toilet, but it
Mhm.
contracts the pelvic floor, can help with pain and urinary symptoms, and it's been,
Yeah.
I mean, personally life-changing for me, but, um, definitely some of
Yeah.
my OBGYN friends believe in that technology too.
Yeah, and that's the thing that I think is amazing is that as women, so we weren't studied in clinical trials until was it the 90s?
I think it was the '90s. I was gonna say, I
Yeah.
don't know the exact number, but that's what I would have guessed too, digging back in my memory.
I know. I'm trying to remember what that number was because I was so aghast. It was too recent. So if we're not mistaken, and if I'm wrong, please somebody correct me. But I do believe that clinical trials with women included did not happen until the 1990s. So in kind of we're not that far off from that, and we're seeing now, like if I go on PubMed and start looking at menopause or looking at perimenopause and just putting in basic things or looking at estradiol or hormone replacement, I'm going to see a lot more studies that were done like the 2000s and up versus prior to that
Right.
now. But also they're actually women. So it's not just a, they're not studying rats, they're studying
We're
actual
gonna
people.
see a ton more because
Yeah.
just hormone replacement, and we didn't even touch on it, but, definitely helps our bones. If you stop it, that effect goes away, and people can die of hip fractures and
Yeah.
not live the same quality of life after a hip fracture,
Yeah.
even more so than dying of breast cancer. In cardiovascular disease, they're finding, hormone replacement helps decrease that risk. It's stable. Hot flashes in the skin too, which I didn't even mention, but
Yeah.
that's like vascular instability. And
Oh my.
so
Yeah.
and think about, a lot of our men will have a heart attack, like, in their 40s, 50s, but women typically have a later heart attack, and there's gotta be some estrogen protection
Yeah.
for folks that then goes away, and then they start having their heart attacks, so and then dementia and Alzheimer's, more women have that, and it's not just because we live longer. There is something there's a Dr. Mosconi, who's doing a ton of research on brain and menopause and
Mm.
estrogen. In fact, I think, Maria Shriver donated a ton of money to be able to test estrogen receptors in the brain, which there wasn't even a test for it until recently, just to kind of understand more how and whether, estrogen can help prevent dementia.
Wow. Wow, this is all the stuff. I think touching on a lot of the myths and the outdated things and all the stuff when I went through questions, I wanted to make sure that I was covering stuff. And that was one of the things I asked is like, what are the things that people we want to myth bust? And it's really what you're talking about is that the impact of sex hormones is systemic. It's not just one area. It's not just hot flashes. It's not just vaginal atrophy. It's not just recurrent UTIs. It's not just a lack of libido. It's bone protective. It's cardiovascular protective. It's brain protective. It
Mental
works.
health, yeah.
Yeah.
Joint
Yeah. Yeah.
collagen in the joints,
Yeah.
there's a whole musculoskeletal syndrome of menopause now. Dr. Vonda Wright is
Yep.
great with that.
Yep.
Frozen shoulder, all these things that we've just sort of accepted and had to struggle with during our menopause years and
Right.
later.
Yeah. I mean, we're worried about whether or not we're going to sweat to death and whether or not we have brown spots and wrinkles. And it's really so much more. So
Yeah.
I'm really, really appreciative that we've gotten to go through this and just kind of look at this. If there was a piece of advice that you could give women, and I know you've talked about vaginal estrogen, but is there one other thing that you think about that's like, if I could just tell one person, do this when you start perimenopause, what would that thing be?
When you start perimenopause, okay, I think educate and advocate for yourself.
Yeah.
If you don't know what's out there, you're not going to know how to help yourself. And a lot of the doctors, we have a whole generation of doctors that don't know anything about hormone therapy
Wow. You just said that
because
out
of that,
loud.
because of that study.
Yeah.
I think someone quoted less than 6% of FP, OB-GYN, and internal medicine doctors get more than 1 hour of menopause training in their training. And so unless they take an interest in learning more, it's not something that's like right on the tip of their head, top of their head when they're
Yeah.
seeing patients. So you have to be your own advocate. I've always told patients that, if I don't call you back, something went wrong, call me. you know,
Yeah. 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 Well,
um,
and
you
I
got to
love
drive
that.
your healthcare a little
Yeah.
bit.
Yeah.
But
I
the
love that.
Empowered Mary Claire Haver has a good book, one of the most popular books out there, but there is like a guide of how to talk to your physician and kind of some labs because she also went through as an OBGYN not being able to help her patients and then started
Mhm.
having the symptoms herself, like, even the cholesterol. Like, why is my cholesterol going up? I'm eating the same, I'm working out
Right.
the same, and it's something in that menopause time frame that changes our cardiovascular sort of function and stability and
Mhm.
yeah, you have to know where to look and where to ask. And if you find clinics that charge a lot of money or say this compound thing is the only way to go and you got to have this, or you got to have this urine saliva test and pay thousands of dollars, you don't have to. If
Right.
you get down a path where you need some specialized tweaking, maybe that's worth it. But to just be able to feel better and decrease some risks is something that you can get through your insurance.
So, Erin, on that note, educating people, I just literally handed out the menopause checklist to two perimenopausal women in the studio. Thank you,
They
girls.
don't
Um,
know.
they
Yeah.
don't know. They don't know. And they were
I
thinking,
didn't know 5, 6 years ago.
yeah, they were thinking that their symptoms were just,
Going crazy, right?
yeah, a little bit going crazy. And I was like, girls, let me hand this to you.
And
So,
it's not the solution to everything,
no, 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 it's not.
but
But
it is a piece of the puzzle when you're not feeling right and you wanna feel better.
yeah. And I think that there was something very powerful in you saying to advocate because that's really what we're trying to do. And it's not that our doctors are trying to be dismissive. I think there are some people who are a little bit, not as helpful and they need to maybe think of a different career if they're that not helpful with their clients. But I think I think that most doctors are just what you've said. They've not been trained or they don't understand what's happening. And it seems like a lot of doctors, when they go through this transition as women, they're like, oh, well, maybe not. And it's kind of a little bit of a gut check or a reality check of like, okay, these clients weren't actually, or these patients weren't actually bluffing about this weird, bizarre symptom. Like I have a client who came in for nutrition that had burning mouth syndrome. And I was
I
like,
think we
I've
talked about
never heard of this. And her dentist and I worked together to try to, see if there was things that we could help her with. And I don't know that she totally solved it, but we did help her a little bit. And it just like, there's all these gazillions of things. I mean, I think, is it in Mary Claire Haver's book, she talks about like there's over 30 symptoms of menopause, and you're
I
just
think
like,
it's like
what the heck?
over 100 now. I know.
Yeah. Yeah. So I
It
think
doesn't
you're
solve
right that,
hormones don't solve everything,
mm-mm,
but we do know that they're a normal part of us as women, and they go away.
yeah,
And, men don't have that happen in their life,
the same
and
way. No.
the same way, and
Yeah.
it should be a normal thing to keep you normal, to keep you kind of
Yeah.
in a state of homeostasis and stability.
Yeah. Yeah, ultimately, yeah. I mean, diet and lifestyle do make a huge impact, but yeah, when those fail, and that was how I got to where I was like, okay, I've had enough. It, yeah, it definitely, because I was trying to do everything natural, and I'm like, this is not working. I'm losing my mind. I'm not sleeping. I'm uncomfortable. I was itchy in my own skin and all of the things. And once I was on hormone replacement for 10 days, it was like the lights went on. And I went, oh, this is what I'm supposed to feel like.
Yeah, I mean, there's lots of we replace testosterone for men. I mean, and theirs is not 0, Uh,
Right. Right.
and there's a whole trend of changing hormone replacement therapy to, like, menopause hormone therapy or just hormone therapy, because it should be a normal part of who you are, you know?
Yeah. Yeah. Well, and we replace insulin, we replace thyroid.
Yeah.
We yeah. There's enough things that we do replace that this should just be another one of those. So yeah, I'm
Mhm.
glad that we're talking through this and seeing this and yeah, getting all of this. I cannot thank you enough for being open and honest with everybody. I think that this is going to shed some light, and I really appreciate that you were um, eager enough to do this with us. And so, when people are in the local Richmond area and they want to come see you for the palm serum, which is your special little mix of stuff to keep their skin looking good, we can reach you at Midlothian Dermatology, and you guys have a website.
Yes, www.midlowderm.com.
Okay. And we'll put that in the show notes. And thank you. This was great. This is
Thank
really
you for having me.
encouraging.
I'm excited to talk about it.
Yeah, we'll keep talking.
Yes, ma'am.
All right. Thank you.
Well, hey, it seems like Ain't Nobody Got Time for That is the theme song to life these days. So thank you for being with me today. I really do appreciate you. And thank you for asking the question, hey Heather, what about? I hope something in today's episode sparked a shift, a breath, or just a moment of, oh, that's for me. If something resonated with you, don't keep it to yourself. Share it with a friend, leave us a 5-star review, and help more people find their way to us. Be sure to follow the show so you never miss a minute of real talk and real transformation. Ready to start your wellness journey? Visit theexquisitehouse.com to join us in the studio or check out The Plan, our signature program for movement, nutrition, midlife, and transformation. Remember, keep asking questions. I'll be here with answers and maybe a reformer spring or two.